Next speaker, Dr. Anu B. John, to tell on recovery of corneal sensation following Phaco versus manual small incision cataract surgeries.
A very good evening to all present here. Thank you, AIOS, for giving me the opportunity to present my research on recovery of corneal sensation following Phaco versus manual small incision cataract surgery. Cornea is a very abundantly innervated structure in the body, and normal corneal sensitivity is very important, which, when hampered, causes a lot of problem to the patient. Cataract is the most common cause of visual impairment and unfortunately can be resolved only by cataract surgery. Phacoemulsification and SICS are the most commonly performed surgeries at present. Corneal sensations can be assessed either qualitatively using a wisp of cotton or quantitatively using a Cauchy-Bonnet aesthesiometer. The aim of a study was to compare the differences in the pattern of recovery of corneal sensation in phaco surgery and SICS using a Cauchy-Bonnet aesthesiometer over a 6-month follow-up period, and to quantify these changes in corneal sensation in the immediate versus late post-op follow-up. Ours was a prospective observational study. First, 100 patients undergoing both either of the cataract surgeries were enrolled and were grouped as phaco for the group 1 and SICS group 2. Any patient who had a pre-existing ocular disorder that could cause a decreased corneal sensation was excluded from the study. CBA was used for the study. Patient was seated at the slit lamp and was advised to look at a straight target. Filament extended to full length of 60 mm. The filament was gently touched on the surface of the cornea at the desired point perpendicular to the surface of the cornea. Filament was then retracted in 5 mm steps each time for a negative response, which is absence of a blink or a subjectively patient telling that he did not feel touch. Filament was sterilized after use and according to the company protocol, and 15 minutes minimally was given for it to be used for the next patient. Measurements were done both preoperatively and postoperatively for 4 visits. Data was entered using epidata and analyzed using SPSS 25. P-value less than 0.05 was taken as significant. 200 eyes in 200 patients were observed. Laterality, sex, and age did not show any statistical difference. The mean corneal sensitivity reduction was seen in postoperative visit 1, which gradually increased and recovered by the postoperative 4th visit. This shows the similar finding with the phaco group achieving recovery faster than the SICS group. This is another graph showing, another table showing the similar change. However, we have noticed that in our institute, since we do a superior incision in cataract surgery, the superior quadrants were affected and the corneal sensation gradually recovered in those quadrants during the follow-up. Cataract surgery is one of the oldest forms of surgery. However, now we do have highly refined surgical techniques, but the patients also have increasing demands and expectations. We have done a 6-month follow-up. The previous studies that were done did not have a prolonged follow-up, and also the trend of recovery was not very conclusive. So the corneal sensations do show a reduction in both the groups. However, the phaco group reached a baseline by 6 months, and SICS group did show a recovery by 6 months. The phaco group again showed a reduction in the corneal sensitivity in the superior quadrants from 10 to 12 o'clock, and SICS group showed from 10:30 to 1:30 clock position. An interesting finding that we had in our study was the paracentesis is also made in a similar fashion at 3 o'clock and 9 o'clock position. There was a drop in the mean corneal sensitivity at 9 o'clock position, which possibly can be explained because we have the right-handed surgeons, and the 9 o'clock side port may be the preferred use of for instrumentation during the surgical procedure. The larger reduction in corneal sensitivity is seen in the SICS group, probably due to the more damage of the corneal nerves than the phaco group, and phaco group also showed a quick recovery of the corneal function post-operatively. There was a linear recovering trend of corneal sensation. The phaco group, again, as I mentioned earlier, showed a faster recovery, reaching the baseline value somewhere between 3rd and 4th postoperative visits. Phaco cataract surgery inflicts lesser damage on the corneal nerves as compared to SICS. It is very important for us as clinicians to be aware of these changes and counsel our patients undergoing surgery to address their expectation, leading to a better post-operative experience for the patient. After all, a happy patient keeps a happy doctor. Thank you.
Does the position of incision makes a difference? Is the
Sorry.
corneal or limbal or some?
Sorry, sir.
If the phaco incision is corneal, phaco incision is limbal, or maybe little conjunctival also. Does it make difference?
So we enrolled all the patients who were undergoing corneal incision phaco, sir.
Clear
So-
corneal.
Yeah, clear corneal incision, sir.
But your SICS were not clear corneal.
So yeah, that was a sclerocorneal tunnel that was created and then entered into the anterior chamber.
Where was the
in the
site
clear
of
corneal, did you go for anterior limbal or mid limbal or posterior limbal
It was anterior into the cornea, sir.
into the cornea?
Yes, sir.
And that was sclerocorneal.
That was a sclerocorneal, sir.
was there any consistency maintained with regard to the SACS length of the surgery
So in our institute, we do a superior incision with 5 mm incision
for all the patients?
for most of the patients. So if we have we expect a larger nucleus or a hard cataract, then we may prefer a 5.5 mm. But yes, the arc length does make a difference.
So even phacos are also done in the superior quadrant.
Yes, sir. We had maintained that sort of uniformity. Thank you, sir.